Should be fine. Yeah, that's about it. It's quite a brief. Am I already live to everybody?
Yes, we already live. So,
oh wow, okay.
If Dr. ready and Dr. Zawani ready, we can start lah.
All
It's already
right.
3.
Okay.
Great.
All right. So we're going to start now, yeah?
All right, great.
All right. Okay.
Yes, good evening, everyone. Welcome to our College of Physicians weekly webinar for the month of January. Happy Chinese New Year to everyone celebrating. So for today, we are very delighted to have Dr. Zalwani with us to chair our current session. The session today will be on medical obstructive jaundice for the physician. So a little bit about Dr. Zalwani. Dr. Zalwani is a consultant physician and gastroenterologist currently based in Hospital Sultanah Bahia, Kedah. She completed her gastroenterology fellowship training in the year 2012 and has served in various hospitals along the northern region of Peninsular Malaysia. Currently, she holds the position of the Head of Department of Medicine for Hospital Sultanah Bahia, Kedah, and she is also the member of the CPG Working Committee for Hepatitis C and also for colorectal cancer. So with that, Dr. Zalwani, the floor is yours.
All right. Thank you very much, Dr. Ko. Assalamualaikum. A very good afternoon to all of you who takes the time to attend today's webinar. A big thank you to the hardworking and dedicated committee who has spent a lot of time in organizing courses like this which benefits, I believe, all of our junior doctors here. Without further ado, I would like to introduce our speaker for today's session, Dr. Glenn George Koleth. He is currently serving in Hospital Sultan Ismail Johor. He had completed his gastroenterology and hepatology training in 2018, a young consultant indeed. And his area of interest include pancreatobiliary diseases and with it advanced in US therapeutic US management. And he also has an attachment in Italy in which he is competent in doing procedures such as POEM, EMR, and EST. With that, I call upon Dr. Glenn to deliver his talk today. Thank you.
Hi, good afternoon, everybody. Thank you, Dr. Zalwani, for the warm introduction. Hope everyone is keeping well. And without further ado, I will share a bit about obstructive jaundice for the physician. Just a disclaimer that I will not be going too deep into the various topics because this is for the target audience of junior physicians and students. So just remember the first picture on this screen here because I'll come back to it later on. And if you can see any abnormalities in it, you already are worthy of becoming a gastroenterologist. Yeah. I don't know if you can see my mouse pointer, but it's where I'm pointing right now. Can you just see sort of a filling defect in the common bile duct here? So these are some of the common things that we encounter as gastroenterologists in our wards or in the medical wards when the patient comes to us with obstructive jaundice and we image them. And sometimes it may be clear-cut, sometimes it may be less clear-cut, as in this case of Malignancy. Right, so let's go to this case of a 35-year-old unmarried Malay lady who presents with 3 weeks history of intermittent upper abdominal pain and 9 days of pruritus, albeit of fever. There is history of consuming some traditional treatment for 4 months leading up to the symptoms, but she denies any blood transfusions in the past and also any alcohol intake, and she is not sexually active. Clinically, there's a tinge of jaundice and her abdomen is mildly tender over the epigastric and the right hypochondriac area. She is clinically obese, but she's stable and she's clinically not septic. So here are her blood investigations. We find that there is a elevated conjugated hyperbilirubinemia with a direct predominant bilirubin of about 67 on admission, and increasing over the days that she's warded into the surgical unit. There is also an elevated alkaline phosphatase, but the good news is that her amylase is actually quite normal. There is ALT predominant transaminitis, but other than that, only a mild hyperleukocytosis, and like I said, her vital signs are quite stable, and she's not septic clinically. So the surgeons decided to post her for an ultrasound, and here we can see, put up the picture with the Doppler so that you can actually visualize the ductal structure that doesn't light up is, of course, the common bile duct and everything around it, which is seen on the Doppler, is a vascular structure and not to be confused with a ductular structure. So you see here in the measurement on the bottom side of the screen is about 7 millimeters. She also, I forgot to mention to you, has gallstones in this ultrasound, in her gallbladder. Yeah. So at this point, what will your clinical diagnosis be? Like I mentioned, she only has conjugated hyperbilirubinemia and a proximal CBD dilatation of 7 millimeters with gallstones in the gallbladder. That's all that they could have seen on the ultrasound. So I know we don't have a poll here, but if you could type into the chat, that would be great. What is your clinical diagnosis at this point? Is it acute cholecystitis? Is it acute acalculous cholecystitis? Is it a just a biliary colic? Because she's got a dilated CBD. Is there an element of cholangitis? Or is it a cholelocholithiasis? Okay, I see some hands being raised. So Dr. Zawani, is it okay if we make this interactive? I mean, I'm not sure.
Sure. Go ahead. Yeah.
Yeah. So, I mean, if you have any questions, please stop me and then we can discuss. And it will keep this quite interactive and less sleepy, I guess, after lunch. So if anyone has any questions, just unmute and just ask, or if you want to raise your hand and say something, just go ahead and do it. Okay, so the correct answer is, of course, cholelocholithiasis, and in an Asian population, we know that stone disease is actually the first and foremost diagnosis that we need to entertain in depending on the population that we encounter, right? Of course, in a meta-analysis done in Netherlands, when they studied about 702 patients, they found that malignancy, pancreatic malignancy, and biliary carcinoma had a higher frequency compared to gallstone disease. But of course, in our Asian population, we find that gallstone disease happens to be the most prevalent cause for medical obstructive jaundice. And if the patient has already has existing gallbladder stones, then there's nearly a 10 to 15% chance that they have stones in the common bile duct, right? And of course, in the East Asian populations, the recurrent biliary infections themselves will predispose the formation of stones within the bile duct, right? It's not just that, they have stones in the gallbladder and the stones are coming out from the gallbladder and sitting in the in common bile duct, but because of the nature of the diet and the infections that we encounter, that in itself predisposes for stasis of bile and eventual bile stone formation. Yeah. Other conditions that promote bile stasis include very large biliary diameters, so common bile duct diameter of more than 10 millimeters in the elderly, will pool bile eventually and forms very, very large stones, as we've seen some elderly people. Cystic fibrosis can also cause strictures and therefore upstream biliary stasis. When we were in Selayang, we definitely encountered patients who have had who had post liver transplants and then come in with surgical anastomotic biliary strictures, which eventually led to stasis. Or some of them had hepatic artery injuries from the transplantations, and they presented with biliary stones as well and strictures. So independent risk factors include a female population for choledocholithiasis, high BMI, and in an Indian study, they studied that chickpea ingestion also promotes choledocholithiasis for some reason. So we try to risk stratify our patients if they come in. The reason being is because we're not going to subject everybody to invasive procedures, and we would like to have some objective guided standards before we actually push these patients for unwarranted investigations, right? So the ASG comes out with high-risk predictors where if the serum bilirubin is more than 68, or if there's a dilated common bile duct of more than 6 mm on ultrasound, then this patient falls into a high risk of having CBD stones, right? However, a smaller diameter CBD doesn't mean that there isn't any CBD stones, right? It's just that with the increments of the size of the CBD, then the percentage of having CBD stones is a lot more higher. So say, for instance, 6 mm here is considered high risk. If you have a 10 mm CBD, then there's a 50% chance that there is already a CBD stone, right? And if there's something less than 6 mm, then you're talking about maybe something like 10% chance, which is a lot lesser, right? Of course, if the patient presents with pancreatitis and you are suspecting from the LFTs, which are deranged, that there are already evidence pointing towards gallstone disease, then by all means, we need to have a high suspicion that this patient's pancreatitis is due to CBD stones, and that needs to be addressed in the admission itself, right? Is there anything about the nature of the pain? I mean, we're all clinicians or budding physicians, and we are not investigative driven, right? I mean, we all have to touch our patients at some point. So is there something about in the history that we find out about the pain that tells us more about whether this is just a cholecystitis or whether it's a choledocholithiasis, right? So the acute presentation of choledocholithiasis will usually present in itself with a prolonged and painful episode, as opposed to a cholecystitis, which has does present with pain, but the pain just subside quite quickly, right? Yes, Zubaida raised her hand. Did you want to say something, Zubaida? You can unmute yourself if you want to ask a question. Nur Zubaida Wahid. Okay. All right. Hello? Right. Okay. So, oops, how do I go back? Right. So, usually in the cases of uncomplicated gallstone disease or sphincter OD dysfunction, or even just functional gallbladder disease, the pain can last less than 6 hours, and it comes and goes, right? So it's intermittent as opposed to choledocholithiasis, right? So in this patient, what will your next steps be? Will you proceed to commence antibiotics? Will you request further blood investigations? Will you refer the surgeons refer her for cholecystectomy? Will you refer her for an EUS? Call me up or Dr. Salwani up for an EUS? Or you request for a CT abdomen? Okay, someone says D. Right. So, yep, that's a good answer. So you kind of we'll go through the different options available, but there is definitely a low threshold to start antibiotics, right? I mean, sometimes when the patient's already referred to us, or sometimes the patient comes to the emergency department seeing that maybe mildly tachycardic with a mild leukocytosis, there can be a low threshold to start antibiotics, and we may order further investigations to rule out infection like a CRP or something of that sort to warrant, to justify the antibiotics, right? Would you go as far as referring to the surgeons for cholecystectomy at the outset, since ultrasound already has gallstones? So we'll talk about that in a second. Definitely, we are moving towards that. But however, it's not yet rolled out in many hospitals yet. But the surgeons have come to a consensus that patients with cholecystitis and choledocholitiasis should be offered a gallbladder removal, laparoscopic cholecystectomy within 24 hours to 7 days. So within the same admission itself, they should be offered a cholecystectomy to be and to remove the gallbladder, right? And I'll talk about more of that in the slides to come. So refer a gastroenterologist for an EOS. Yes, we are all here for your EOSs, so please refer. And when will you request for a CT abdomen in a patient like this? So the next steps would include definitely an EOS. The ASGE recommends that if a patient falls in an intermediate risk, where the age can be more than 55 and abnormal LFTs and only a dilated CBD. Of course, a high risk would be an obvious CBD stone present. Then in these cases, the additional imaging is required, right? EOS is more sensitive. It's proven in multiple pooled analysis compared to an MRCP and compared to a CT, right? But there are times when we may consider doing a CT as opposed to an EOS on MRCP at the first instance, right? For example, if this patient overnight after the referral to the gastroenterologist for an EOS, while they're waiting for the EOS in the morning, overnight she turns really bad and the clinical scenario becomes worse and she gets admitted to the ICU and she's now on high flow mask or she's on a venti mask and she's become acidotic. So clinical state has been compromised. So these are when non-invasive procedures are extremely valuable. And for instance, if this patient had presented with a very severe pancreatitis at the outset with very severe abdominal pain, and you would like to rule out, a perforated viscous, then by all means, a CT is actually warranted at the outset. Yeah, it is more sensitive compared to sonography to pick up cholecystitis. And in some centers, of course, most private centers, possibly without the help of a gastroenterologist, you could proceed with an MRCP. But if there are no stones on the MRCP and there still is high suspicion of choledocholitiasis, then an EOS is still warranted, right? So we'll look at some of the risks and the benefits of having an MRCP versus an EOS after this. So she did I did proceed with EUS for her. And as you can see, oops, let me just back up. So that's the versum coming right at the bottom of your screen right there just now. This little duct here. And then this common bile duct is above it. You can see how thickened the wall is and how dilated the common bile duct is. And can you see something sitting just here towards the end, and it's casting an acoustic shadow all the way down here. So this is from the descending duodenum when I examined her, looking at the uncinate, and now I can see a distal CBD stone just sitting right there. Yeah. So whom do we select for an MRCP versus an EUS? Like I said before, some centers, where we have MRCP readily available, then I think by all means, if the patient is unfit for invasive procedures, then the MRCP is indicated. But in most centers like ours, I think in the government setting, we may even just replace the MRCP with a CT, but that would mean that sensitivity of the test reduces. Not all stones are radio opaque and are seen on a CT. So you may miss these stones, CBD stones, which are sitting there in a CT and are probably better off seen in an EUS, right? The advantage of having to do an EUS is that, yes, it's invasive, but as soon as we secure the airway for an EUS, we can straight away proceed with an ERCP, and we can offer therapeutic solutions after the diagnosis has been made. The probe of the EUS comes very close to the bowel wall and to the whole biliary system, so we can actually look at the biliary tree and visualize it very, very well. We can even measure the stone size so that we can estimate what balloons that we're going to use for the ERCP, and we won't go in blindly. We know roughly, we can have some sort of strategy when it comes to stone removal as well. And the thing about an EUS is that, yes, it's more sensitive compared to a CT, nearly more 16% more. And so in an older population, you may miss, smaller hypodense areas in the pancreatic head, which could actually prove to be an NET or some sort of malignancy, which could have caused the pancreatitis to begin with. And the gallstones may just be a red herring all along. Yeah. So that's something that EUS can be superior to conventional MRCP or non-contrasted CT, right? But of course, in patients with extremely altered anatomy, where the scope may be impossible to pass through the pylorus, if there's non-existent pylorus, or in such cases, then CT would be warranted. So, what happened to this lady? I took her in for an ERCP, and the common bile duct was actually not very dilated. There were some stones. The intrahepatics were not dilated at all, but I found it extremely difficult to trawl the two little stones. There were actually one on distal, and then there was one on top, but it was extremely difficult to trawl the balloon out. And I thought that maybe the stones were a little large. So what I did was I tried to dilate her tract, just the ampullary orifice, after making a sphincterotomy with something called a CRE balloon, which is a graduated balloon that gradually increases as we apply contrast and fluid into the balloon, and in a stepwise fashion. And if you see, there's a waist in this balloon that has not disappeared. So with the radial force that the balloon exerts on the sphincter, this wasting should disappear. And it would be so much more easy for me to trawl down the stone of the balloon. But if you can see in the picture on the right here, if you look at my mouse, there's this thick band around where the wire is, and this is inside the bile duct. And if you can see, this is actually fibrotic tissue, right? It doesn't look malignant to me, but this looks like a fibrotic stricture, right? This is the duodenal wall. Of course, I'm not permitted to cut anymore here because it will cause the perforation. So that in itself is one of the second most highest causes of benign biliary obstruction in an Asian population, which is actually biliary strictures, right, which cause biliary stasis and eventually gallstones. So it's more of like a chicken and egg kind of situation. Did the stones cause the fibrosis by recurrent inflammation? That is also another possibility, but the stricture itself can in turn cause more bile stasis. So what I proceeded to do is to stent her with 2 stents, and we'll come back and we'll try to dilate the stricture, and we'll see how she goes from there. So an approach to conjugated hyperbilirubinemia, warrants some form of further imaging, especially when there's elevated direct hyperbilirubinemia and ALP. But if the imaging is negative, then we need to consider other causes, non-surgical causes of intrahepatic cholestasis, right? Such as primary biliary cirrhosis. So we need to include AMA in the bloods that we sent off. This patient could have a dominant stricture that could result in hyperbilirubinemia that we need to stent as well. There could be a hepatocellular injury from either viral hepatitis, Wilson's, hemochromatosis. So, your transferrin saturation, serum iron, all that's important to be taken as well, along with your serum ceruloplasmin, and other inherited conditions that can cause isolated direct hyperbilirubinemia, include rotor or Dubin-Johnson, which both are benign disease. And then also commonly in males, we see Gilbert's, which causes unconjugated hyperbilirubinemia. Gilbert's per se can predispose to stone formation as well. So that can be another reason for the stones to be formed. However, these patients only have hyperbilirubinemia and not have any other deranged liver markers, right? So this is something to note as well, moving into the causes of jaundice. So some key points from just this scenario itself is just that EOS and ERCP should be offered to all patients suspected of a CBD stones and are stable enough to undergo the procedures. But we also need to consider other causes, benign causes, like other than just stones, like Meritzi's, and also benign CBD strictures. So a laparoscopic cholecystectomy should be offered to the patient within the admission itself, even when there is choledocholectasis. So now the consensus is that we, as the gastroenterologist, proceed to clean the bile duct or remove the stones, and then the patient goes for the cholecystectomy, right? The previous school of thought was there could be lots of inflammation and it could be extremely difficult to remove the gallbladder with suture dehiscence, bile leak, and those kind of things. But from a recent review, there has been no difference between the conversion of a lap chole to an open chole if cholecystectomy is to be done within 7 days or 5 days, or even delayed as to old times before. I mean, after 6 weeks after the admission, which is usually how it's done, right? So the surgeons think that the inflammation itself tends to sort of open up the planes to make things more dilated, easier for them to operate and cut and remove. So that's one theory behind why the cholecystectomy should be done in an earlier setting. Yeah. Oops, I've got a chat. Didn't look at that one. Oops. All right. So yeah. So I'll give you another scenario which I didn't put up here as well. So in a young lady as well who presented with deranged liver function and also hyperbilirubinemia, and the imaging actually showed her to have a Malignancy syndrome. So the CBD was stented with the ERCP, and they proceeded to remove her gallbladder, right? And because the bilirubin was not really coming down, so they removed the gallbladder, and the HPE of the gallbladder actually only showed very mild inflammation. And this is contrary to what you would get if there was choledocholitis and cholecystitis. Cholecystitis will always produce very florid inflammation in the gallbladder wall. So with mild inflammation, they proceeded to revise the pathology report and look into it again, and they actually found abnormal cells within the gallbladder wall in a young lady. And turns out that she actually had concurrent anemia as well. And these abnormal cells on further staining actually proved to be an adenocarcinoma. And where did she get it from? Actually, she got it from the stomach. So it was actually a local T4 tumor that had spread to the gallbladder and also had caused jaundice and deranged liver function. So something to keep in mind as well. Okay, so other malignant causes of benign biliary obstruction, I mentioned the first two. The last one, this is a case that we recently did here as well. If you can see, so this lady was around 75 years old, and she presented with jaundice and also elevated bilirubin of about 80 plus, going upwards in trend, and she also elevated alkaline phosphatase. And they proceeded to do an ultrasound, a trans-abdominal ultrasound, and the report says yes, dilated common bile duct, and there was stones. So naturally, with that, she falls into a high-risk category for me. So I proceeded to do an ERCP for her. And lo and behold, on the fluoroscopy, before I even injected any contrast, I find that there is actually a hyperdense area here, just on X-ray alone. And it was extremely difficult for my wire to go in. And I realized at this point in time that this stone was not in the common bile duct. It was actually in the pancreatic duct. And the pancreatic duct has now, full of these huge stones, was actually compressing on the distal CBD, causing her bilirubin to go up, and for her to actually have direct hyperbilirubinemia. So what I did was to proceeded to stent her pancreatic duct. You can see a small pancreatic stent here, and I've also stented. I also put a wire up into her common bile duct and put a stent into her common bile duct, and then I repeated an X-ray because I realized that this was not normal, right? And so you can see on the X-ray here these giant pancreatic duct stones, and also another dilated duct at the bottom here. And so she's got huge stones inside the pancreatic duct itself, causing ductal hypertension and pain. So that was really the cause of her pain. But the jaundice was because these stones were actually impinging on the common bile duct. So, chronic pancreatitis can also be another cause for biliary obstruction. Do take adequate history when it comes to these patients to find out if there are any exocrine or endocrine insufficiencies as well. So moving on to more less benign conditions. This is a 53-year-old Army veteran who presented with oh wow, there's 141 participants. This is stressful. Okay, there's a 53-year-old Army veteran who presented with jaundice and low blood pressure and per rectal bleeding. and actually already had a prior history of being diagnosed to have rectal adenocarcinoma late last year, which was diagnosed to be stage 4, and he was started on a palliative chemotherapy regime. Unfortunately, at this point in time, he became later on in the year, he developed jaundice, right, to the end of the year. And so when he came in this early January, he was very deeply jaundiced, but he was having a poor hemodynamic status on arrival. Clinically, his blood pressure needed volume resuscitation, but also required in the end inotropic support. So we did start him concurrently on antibiotics, even though the total white was not so high. You can see the bilirubin climbing very, very much in this setting. Sometimes, it may not just be an obstruction that we may be dealing with, but the fact that he may be having a concurrent infection can also be contributing to the rise of the bilirubin. So, I did give some answers away, but what will your next steps be? You can pick any two for this patient. Otherwise, I will proceed to give you the answer. So know that he actually had a CT done in October last year, already showing liver metastasis and mild biliary obstruction. But from October till now, he's been pretty stable. He's been on palliative chemotherapy. And just now he's come in with low blood pressure and PR bleed and also jaundice. So right. So Eugene says that he'll probably go with a very conservative, stepwise physician approach, which is start antibiotics and then not piss off the radiologist so much and order an ultrasound at the outset. Anyone else for anything? So I think those are really good choices. It's just that I would probably proceed to push for a CT as soon as possible. Why? Because the CT is a roadmap for the gastroenterologist to know where and when or how they should plan their next steps, especially to show us a route for which the wires should go in and which lobes we should be injecting contrast or not injecting contrast into. So as you can see here, very nicely, there is a tumor starting to show up here. Of course, there are multiple metastases everywhere, but as you go down, you can see the hypodense area now compressing the hilum with very nicely dilated right and left biliary system. So never be afraid, even though if you're physicians, don't just read the report. Let's just open the CT and you'll be very pleasantly surprised that actually we can read CTs. It's not impossible to read CTs. It's not impossible to know where the pancreas is and the CBD, and you can trace it from there. This is just one of those occasions where we can very clearly see a non-contrast filled structure, which is the ducts. The contrast filled structures are the arteries here, right? Or the vessels. So there's not much ascites. This is another thing that is also something that I would be looking for as an interventional endoscopist, because I would want to know the distance. If I would like to drain the left lobe through the stomach, I don't want to have much ascites, and it's also good. It's also good for me to know that there's a backup plan for percutaneous biliary drainage as well from out here. If there's no ascites, then I can refer to the interventional radiologist to put a drain in from here if the ERCP fails. So next steps, we covered him with inotropic support and antibiotics, and proceed to take a high risk consent as his ejection fraction is pretty poor. we proceeded with an ERCP. Yeah. So sorry, the pictures are not so clear, but as you can see, thankfully, we were able to admit the wire through the tumor, and now we are looking at an area here where the contrast is not filling up. And so that's a strictured area right here, if you can see that. And so that shows me how much of area is strictured. Also tells me that this right side is not communicating with the left side completely, right? So due to cost issues, we decided to only put in one stent. We started stent the largest part of the liver, which is the right lobe. And you can see now the kink in the stent is just about here. The stent is very nicely draining all the contrast out from the right lobe, right? So bilirubin comes down. So I'm almost done with my presentation so that we can go on to other causes. I mean, other questions. But so I think we lack local data for the actual causes of malignant biliary obstruction here in Malaysia. But from my short tenure as a fellow and now a junior gastroenterologist, CA head of pancreas is something that we encounter most of the time. And next after that is really just the carcinoma of the periampullary region. Gallbladder cancer is not as common as we would have seen CA pancreas in Malaysians. But of course, in other populations, Indian population, gallbladder cancer is very, very high. But we also need to not forget that malignant infiltration of portohepatic nodes, as in the case of even lymphomas, can cause malignant biliary obstruction. They need to be sampled, and they can be easily overcome with stenting as well. So sometimes the liver can be eroded or studded with many metastatic deposits, and that can cause focal dilatation higher up in the liver. But sometimes there may be no dilated ducts at all. So if a patient who has malignancy comes in with jaundice, that could be a purely infiltrative disease that is affecting the patient's biochemistry. And that means that it is pretty much the end of the line for the patient. And it's not very much that we can offer after that. So we've all heard of Courvoisier's law. It's not a law per se, it's just a hypothesis, and there are times where there will be exceptions to this rule. But one thing to note is that gallbladder, usually if it's palpable, in the case of jaundice, then we need to suspect malignancy, because a tumor at the head of the pancreas will cause constant back pressure up into the gallbladder, into the biliary tree, as opposed to cholecystitis, which comes and goes, causing inflammation, subsiding, and subsequent resolution of the inflammation leads to fibrosis. And so the gallbladder doesn't distend so much for it to be palpable. But of course, in chronic stone diseases, sometimes, and also GBM paima, you may be able to palpate this gallbladder as well. Yeah, so that's all for my presentation. Is there anyone else who would like to ask any questions? Please go ahead.
Okay, thank you, Dr. Glenn. To the audience, probably the topic is a bit misleading, yeah? I think it should be jaundice for gastroenterologists, yeah? All right. Of course, in a center which has a gastroenterologist, most of these jaundice patients will end up in our unit. But in centers without gastroenterologists, you have to decide whether this is a medical jaundice or a surgical jaundice. Yeah. All right. So I think from the first case scenario, if you remember the liver function test, then would you be kind enough to scroll back to your presentation? Okay, right there. Okay, has an attending doctor, I think you should be able to make some conclusion from the LFT. What kind of derangement does the LFT shows in this patient? Yeah, clearly this patient is jaundice, and you can see that this patient has predominantly hepatitis, isn't it? ALT definitely about 10 times upper limit of normal. The ALP is relatively in acceptable normal range. All right. So in a patient with this kind of jaundice, I would not blame anyone if you say this is acute hepatitis. Yeah. All right. The usual panel that you would need to send is of course your hepatitis panel. And imaging, of course, most often than not, it is being done for jaundice patient. And in this patient, incidentally, that the CBD was noted to be dilated. That's why Dr. Glenn proceeded with and further investigation, which is EUS. All right. So if you ask me why does choledocholithiasis does not cause the patient to have ALP to be raised, in some instances you can get predominantly cholestatic picture. In some patients, you get mixed picture for choledocholithiasis as well. All right, if there is a gamma GT available, probably it would good as well to have that panel of investigation done. All right, so as a clinician, I think you need to be able to discern whether what kind of liver injury or liver pattern of the liver injury the patient is having, whether this is hepatitis, mixed pattern, or predominantly cholestatic. From there, you could make some deduction whether this is a medical jaundice or surgical jaundice. As Dr. Glenn is a gastroenterologist, he handles, I think, both medical cause of jaundice as well as surgical cause of jaundice, such as gallstone, strictures, and malignancy. All right, so that is for a clarification. All right, so not to confuse the junior doctors and students. All right, so any questions regarding to this topic of presentation today? You can either type in the chat or you can speak if you prefer to speak.
So Eugene asked a question, Dr. Zalani. Is it okay if I bring that up?
Sure. Go ahead.
Yeah. So it says that if we have a patient presenting with jaundice, blood showing cholestatic hyperbilirubinemia with elevated ALP, but ultrasound shows that the biliary tree is not dilated. Okay. So apart from sending off autoimmune workup, viral serology, etc., is there any other role for further imaging, EUS, etc.? So yes, like I said before, if we categorize these patients based on the population that we are seeing them, if you're talking about a young patient with high index of suspicion that this is gallstone disease, although like Dr. Zawani said, the ALP may be not elevated, plus minus. You may want to do further GGTs and things like that. But the thing about a dilated CBD is that you can even have a smaller diameter CBD of less than 5 mm, not necessarily dilated at all to begin with. And that's why the ASG says 6 mm. Actually, when we first taught EUS, we were told that, okay, 8 mm and above is, dilated, etc. But, ASG has brought it down to 6 mm. There are some places where the CBD is only about 4 mm, and we still see stones within the CBD. So because the sensitivity of the EUS scope for it coming so close to the biliary system, you can see so many things. So that's why it's a valid thing to order an EUS. If it's not present, then we try for an MRCP. One more thing I talk about for an EUS as well. For this lady per se, one thing that we may need to consider as well, if the liver enzymes keep going up, there is a direct hyperbilirubinemia. The good thing is that while we await for the autoimmune markers to come back, we may get, serum IgG, which is elevated, or we may have a globulin albumin ratio, which is actually a bit more higher. And so we're thinking about maybe an autoimmune hepatitis at the back of our mind. And she would probably have a normal finding on EUS. So one thing good about EUS is that we can counsel the patient at the outset, sort of a one-stop shop thing, that we can proceed with the liver biopsy in the same sitting, take liver biopsies. Of course, patients in counsel and told about this as well. And then we can have tissue available, and we can make a diagnosis quickly and start, if we need to, steroids quickly. So they said the surgeons sometimes tend to conclude that the patient do not have obstructive jaundice as the biliary tree is not dilated. Yes, from an ultrasound, but so many factors can compound to the ultrasound showing a very poor image. Patient could be high BMI, flabby abdomen, ascites, so many other things. So definitely sometimes further investigations with a second mode of imaging is warranted. So Eugene also said, in centers without gastroenterologists and no immediate access to ERCP and EUS, any comments on the role of UDCA? Okay. So UDCA does provide some symptomatic relief to the elevated bilirubin. But if the diagnosis of biliary obstruction is still present, then it may partially only cause some sort of relief, but really not to the point where it's definitive. So I think that's something that will not be our first line, but will probably be the last thing that we reach for in the bag to actually start for a patient with jaundice, and we have not established the fact that this patient has some sort of autoimmune disease. Yeah. Sorry, Dr. Salani, would you like to add on that?
Okay. For patient with medical obstructive jaundice, usually it's intrahepatic cholestasis. Yeah. All right. So when you see the LFT showing predominantly cholestatic picture and without any imaging studies, either ultrasound, CT or ERCP, or even US showing any obstruction in the intrahepatic or extrahepatic ducts. All right, and so usually what we most of the patient would end up having a liver biopsy all right, and while waiting for definitive sort of diagnosis, of course, most of our cholestatic medical jaundice patient will start on UDCA as well. Yeah, but of course, you would like to have a definite diagnosis for your patient. The common causes for cholestatic jaundice in our medical ward, we're not talking about stones, strictures, malignancy, will be of mixed etiology. They are usually on multiple drugs, so drugs are quite common causing cholestatic jaundice, sepsis as well, and some patient has a congestive hepatopathy, they have cardiac failure, so you could see them to have a higher bilirubin, about 100 to 200, and ALP of about maybe 10 times upper limit of normal. So most of these kind of patients have multifactorial causes for this cholestatic jaundice. Again, like I said, if possible, we would want a definitive diagnosis. A liver biopsy is usually offered to the patient. And one of the serology that we usually do for our cholestatic jaundice is AMA. AMA, ANA, liver antibodies as well. And some patient also we will send IgG4, whether we need to consider whether patient have autoimmune cholangitis as well. So this sort of obstructive jaundice sometimes quite difficult to put a clear cut whether surgeon handle or medical handle. But like I've said, in a center where there is a gastroenterologist, we are the one who usually handles from the start. And once we get a definitive diagnosis, let's say this is a malignant stricture, so we will channel to the hepatobiliary surgeon, or this is a pancreatic head of cancer, of course, we land up to the surgeon. So there is an algorithm for us to follow when we see a patient with obstructive jaundice. Yeah, all right. I hope this clears a little bit of the probably confusion. Yeah, all right. Some of you might ask why this patient land up in surgical ward, why this kind of patient land up in medical ward. Like I said, sometimes it's quite difficult at the onset to say what kind of jaundice this patient has. All right. Sometimes it's the history itself can give you clues. Patient who has a sudden onset of pain or that, of course, think about stone or that. Yeah. All right. Those who has a significant loss of weight, loss of appetite, with let's say weeks of jaundice, always think about sinister causes as well when you see a patient who has cholestatic liver injury. All right. So all in all, you need to have a what do you call that? A comprehensive understanding of your patient all right. So based on history, from the liver panels, from the imaging that you have done, you should come to some conclusion of what your patient is having before you advances to other specific investigation like US, ERCP, or that, yeah, MRCP, or that. All right, I hope that clears the air a little bit. Yeah.
There is also two other questions, but yeah. Okay, so I just wanted to share a bit on the role of UDCA. Yeah, so we can also add cholestyramine as well if just to manage the symptoms. It's really purely symptomatic relief until we find a definitive diagnosis. So Adrian Chong has asked, I have a young, is it a lady? Gentleman, okay, young patient, gentleman in his 20s with features of ascending cholangitis, raised direct bilirubin and alkaline phosphatase, but clinical and biochemical parameters improved with antibiotics and supportive treatment. Inpatient ultrasound was done, normal. CT, EOS, normal. Viral Hep negative, patient was discharged. Is it possible to be passed out stones if the biliary tree is not dilated? No cholelithiasis. If so, how do we work up this patient? Extremely good question. If we are entertaining that if this young patient, this gentleman, even from the outset, the ultrasound does not show any gallstones, right? The patient has come in with jaundice. We do an EOS, and there's nothing to suggest structurally that there is anything wrong with the bile duct. If there was a passed out stone, one stone from the gallbladder, it's a bit unlikely it just came out. And if it was, the gallbladder lining wall would have been thickened, right? There could have been some element of thickening of the bile duct, like how you saw in the EOS that I showed you. You can see the biliary wall, the CBD on both sides thicken. So if there can be a situation where there has been acute acalculous cholecystitis, where this patient has features of suggestive of cholangitis, pain, and we've covered with antibiotics and everything resolves, right? But like I mentioned before in the scenario towards the end, if this patient has anemia, there could be a high suspicion that there may be some sort of malignancy that we may be missing as well. So sometimes if this patient comes back again with another episode of cholangitis, it may be warranted to refer this patient off for cholecystectomy, because there could be something that we may be missing histologically until we remove the gallbladder to look for it. right? But then again, to follow up this patient, we would like to see the patient at least once in the clinic to review the LFTs as gastroenterologists, and to know whether we need to do a second line workup for this patient and look at all the other causes leading to raised transaminases with hyperbilirubinemia, whether it's going to be conjugated, mixed, or unconjugated. We would like to know whether we're dealing with Wilson's, or whether this could be some sort of liver disease that warrants a biopsy or further investigation. Yeah, I hope that answered the question for Adrian. Tan KK asked, is ERCP having a role for diagnostic purpose to find the cause of obstructive and cholestatic jaundice? So the risk stratification that I mentioned earlier about whether this patient is high risk, intermediate risk, or low risk. So high risk is that the patient has already an elevated ALP, increased bilirubin, and already a CBD stone on an ultrasound. Then you can go in straight for an ERCP. But if that's not present and only a dilated duct of CBD of more than 6 mm or more, then we would push the patient for something less invasive, like in EOS first, because the ERCP would carry nearly a 15-20% chance of pancreatitis, which we would not want the patient to be exposed to unnecessarily, especially if they are female, a bit on the large side, young. Then the risk of post-ERCP pancreatitis is very high. So nowadays we will not proceed with an ERCP for diagnostic purposes. It's just not something we do anymore. Yeah.
So when you do ERCP with a therapeutic intention, yeah, basically.
Yes, exactly.
Yeah.
That could also mean if we find a stricture, we can biopsy it then and there, or do brushing cytology and send off for immunohistochemistry staining to know actually if we're dealing with a cholangio-CA, etc.
Any more questions from the audience? All right, I think they are all happy now. Right, I think it's 4 o'clock already. All right, okay, I would like to thank Dr. Glenn for a very interesting introduction to EUS, ERCPs, yeah, and how a gastroenterologist manage obstructive jaundice. And also thank you to the organizing committee from the College of Physicians of Malaysia for continuing to encourage our young doctors to keep up with the latest of our medical education program. Thank you very much.
Thank you, everybody.
Thanks, Dr. Zalwani. Thank you, Dr. Glenn, for your time. It was really good. Stay tuned.